He stopped sleeping. Not gradually, not in the way most people describe poor sleep. He simply stopped. And the nights that followed were unlike anything medicine had encountered before. His name has been kept largely private in most published accounts. What is documented is this. He was an Italian man in his mid-50s. He had a family, a profession, an ordinary life by every visible measure. In the documented case records, his story begins the same way many do, with something small that refused to go away. He began having trouble sleeping. Then he stopped sleeping entirely, not for a night, not for a week, for months. The records indicate he first noticed the insomnia in the mid-1980s. He reported it to physicians. Blood work came back normal. Neurological exams found nothing alarming. A psychiatric evaluation suggested stress and anxiety. He was told to rest. He could not rest, because the mechanism that allows the human brain to fall asleep had, according to later research, already begun to fail. Over the weeks that followed, the situation deteriorated in ways that were difficult to document because they were difficult to believe. He described sensations of exhaustion, unlike anything he had felt before. His body was tired. His mind would not dim. He would lie down. Hours would pass. Nothing. Not a minute of sleep. His family watched him move through the days and nights without rest, growing thinner, more confused, more distant from the person they had known. He went back to physicians. More tests, more referrals. The same conclusion. Nothing was found. The human brain requires sleep. Every physician who examined him knew this. What they did not yet know was why his brain had lost the ability to achieve it. He was not choosing to stay awake. He was not anxious in the conventional sense. Something structural had gone wrong. Something the standard workups of the 1980s were not designed to detect. And while the tests found nothing, the weeks without sleep continued to accumulate. He began to experience what the records describe as autonomic dysfunction. His body temperature became irregular. He sweated without cause. His heart rate elevated and would not settle. He began to have episodes of what appeared to be waking dreams, visual disturbances that occurred while his eyes were open. His family described watching him reach for things that were not there. He would speak in fragments, then return to himself, then drift again. If every test came back normal, perhaps it really was something psychological. That thought does not appear in the case records directly, but it is the thought that follows any person through years of unanswered medical visits. His family continued searching for answers. He continued not sleeping. He could no longer work. He could no longer hold a sustained conversation. The man his family had known was present in his body, but increasingly unreachable. But here's what made this case different from everything doctors expected. He was not the first in his family. The records show that other members of his family had died from what had been recorded over generations as encephalitis, brain inflammation of unclear origin. They had all followed a similar path: insomnia, cognitive decline, death. The pattern had been there for decades. No one had connected it. The physician who eventually made the connection was Dr. Elio Lugarisi at the University of Bologna. According to published case literature, the patient was admitted for observation, and extensive sleep studies were conducted. What the polysomnography showed was not disordered sleep. It showed the near-complete absence of sleep architecture. The slow-wave sleep stages that allow the brain to repair itself were essentially gone. REM sleep had collapsed. What remained were brief, shallow fragments, not enough to sustain neurological function. Fatal Familial Insomnia. a prion disease so rare that the medical literature had, at that point, never formally described it. It is caused by a mutation in the PRNP gene, which provides instructions for producing a protein called PRP. In fatal familial insomnia, a misfolded version of this protein accumulates in the thalamus, the region of the brain that acts as a relay station for sensory information and, critically, for regulating the sleep-wake cycle. As the misfolded prions destroy thalamic tissue, the brain loses its ability to initiate and sustain sleep. The destruction is irreversible. According to published research, fewer than 200 families worldwide carry the genetic mutation associated with fatal familial insomnia. It is inherited in an autosomal dominant pattern, meaning a single copy of the mutated gene is sufficient to cause the disease. A child of an affected parent has a 50% chance of inheriting the mutation. The condition typically manifests in middle age, between 40 and 60 years old, after decades of normal sleep and ordinary life. The progression described in the case records follows 4 documented stages. The first, worsening insomnia, panic attacks, and irrational fears. The second, hallucinations, increasing confusion, and visible weight loss. The third, a complete inability to sleep, combined with rapid cognitive deterioration. The fourth, dementia, unresponsiveness, and death. The disease is currently without a cure. Treatment options are limited to managing symptoms. Sedatives and sleep medications, according to published literature, have shown little effectiveness. The brain's sleep architecture has been structurally damaged, and chemical intervention cannot restore what the prions have destroyed. What researchers cannot yet fully explain is the precise mechanism by which the thalamic damage produces the total loss of sleep. Studies using functional imaging have shown the extent of the damage, what triggers the initial misfolding of the prion protein, and why the thalamus is the primary site of accumulation in this particular mutation remains poorly understood. And then came a finding that changed how physicians understood this. The case records of this patient, published in collaboration with researchers including Dr. Pierluigi Gambetti, became the foundational description of fatal familial insomnia in the medical literature. The condition was formally named and described as a distinct prion disease, separate from Creutzfeldt-Jakob disease, which it resembles in some respects, but distinct in its thalamic specificity and its sleep-related presentation. This reclassification mattered. It meant that physicians encountering future patients with progressive insomnia and cognitive decline now had a diagnostic category that had not previously existed. What this case also revealed was a gap in how medicine approaches sleep disorders. For years, intractable insomnia was managed as a psychological or behavioral condition. The idea that a structural, inherited prion-mediated disease could destroy the brain's sleep apparatus was not part of standard diagnostic thinking. This patient's documented case, and the years of misattributed symptoms before the correct diagnosis, helped shift that thinking. It introduced the concept that some presentations of insomnia are not psychological in origin, and that genetic screening may be relevant in families with documented multi-generational histories of unexplained neurological decline. The family's story did not end with this patient. According to published accounts, family members who knew they carried the genetic mutation have had to live with that knowledge across decades. Some have participated in research, a case documented in later years, covered by several science journalists and medical writers, including a detailed account by D.T. Max in his book The Family That Couldn't Sleep, describes family members navigating the inheritance of this mutation, some choosing to know their status some choosing not to. There is no preventive treatment available. Genetic counseling is the primary resource offered to families who carry the mutation. Research into prion disease mechanisms continues, and a small number of experimental approaches have been proposed. But as of the time of this script's production, no intervention has demonstrated the ability to halt or meaningfully slow the progression of fatal familial insomnia. What this condition reveals about the brain is precise and, in some ways, clarifying. Sleep is not simply a behavior. It is a biological process with a specific structural architecture, maintained by dedicated regions of the brain and irreplaceable in its function. When those structures are damaged, no amount of exhaustion, relaxation, or pharmacological sedation can substitute for what is lost. The body needs sleep, and when the mechanism that produces it is destroyed, the body cannot survive. He had not slept in months by the time a diagnosis was reached. The diagnosis did not change the outcome, but it changed what medicine understood. He stopped sleeping one night, not gradually, not in the way most people describe poor sleep. His body was exhausted, his mind could not dim. And somewhere in the thalamus, a small, quiet region most people have never heard of, something had already gone wrong years before the first sleepless night. If you had watched someone you loved lose sleep, then lose weeks, then lose themselves, and every test came back normal, would you have known what you were looking for? This video is based on real, publicly documented medical case reports and is intended for educational and storytelling purposes. It is not medical advice. If you or someone you know is experiencing similar symptoms, please consult a licensed physician. Medical Mysteries, true cases every week.